Hello everyone, you're watching sqadia.com and we are now on the pathology of rheumatoid arthritis. We have just came to know that what are the causes and different factors which have their role in rheumatoid arthritis. But what actually happens is when the rheumatoid arthritis starts to develop in the body. We will be going through the pathology and the pathogenesis of RA. Then we will be going through the stages of disease progression, how from a simple mild arthritis it goes into a full-blown arthritic joint and deformity. Then we will also be going through the extra articular manifestation, as we know that rheumatoid arthritis is not a disease confined to joints, but it affects other organ systems of the body as well. The synovium is engorged with the new blood vessels and packed full of inflammatory cells. There are actually four stages which confirm the pathology of the rheumatoid arthritis. There's a preclinical stage, then there is synovitis and inflammation, then there's a destruction of joint, and eventually the development of deformity. Then you need to remember that actually it's for the sake of understanding, it's been divided into four. But once the cycle sets in, then the patient that progresses from a preclinical stage to first, and then to second, and then to the last stage. In the lower diagram, you can appreciate this is a histopathological slide of a synovium, which is actually showing a lot of blue dots because there's a high amount of neutrophilic infiltration and inflammation of synovium, which is occurring in the rheumatoid arthritis patient. Now coming to this is also a diagram which is showing how the stages actually progress. On the left hand side, you see a normal joint with a thick cartilage, enough amount of synovial fluid, and there is no actually hyperplasty of the synovium. But once initially there's synovitis, inflammation sets in, and there's increased production of synovial fluid resulting in swelling. As these interleukins and cytokines are being produced, this also cause production of pain. Once this happens, there's a stage in which the normal cartilage is getting destroyed by these macrophages and other cells. And once the whole of the cartilage is destroyed, there's a complete ankylosis of the joint, resulting in a deformity. And the end stage deformity is actually non-reversible. So we may have to surgically treat this kind of a stage. But for before in preclinical stage and initial stages, medical treatment may be enough. Now coming to the stage 1, this is termed as preclinical stage. There is raised ESR, C-reactive proteins, and RF factor may be detectable years before the first diagnosis. Now this is important that RF factor, as I told you, may be positive only in 70%. So we have to see whether if the patient has any symptoms or is there any family history of rheumatoid arthritis or not, and then we have to establish whether it's an early RA, established RA, or it's not an RA. Then there are no actually clinical symptoms, and usually patients don't come and consult in this stage because there are no basic symptoms. There may be mild symptoms of arthralgias, but usually there are none. Now coming to the stage 2, and this is actually marked by synovitis. Synovitis is the inflammation of the synovium. There is vascular congestion with new blood vessel formation. There's proliferation of synovicites, which actually not only increase in number, plus they increase the production of synovial fluid. Infiltration of the subsynovial layers by polymorphs, lymphocytes, and plasma cells. Now this all leads to the thickening of the capsular structures. Now what happens is when all this is happening, there are furrows or burrows being produced which take a form of a villi in the spinous, and this is called a villus formation of the synovium. This becomes so hyperplastic that actually it folds on itself, and because it has increased in size now. Now this cell-rich effusion into the joints and tendon and sheaths, and now from joints spreads to the nearby ligaments to tendons, which are crossing the joint, and resulting in the formation of the ligaments and tendons and thickening of the tendon sheaths, leading to us full-blown synovitis. The next stage is the stage of joints destruction. Once The persistent inflammation causes joint and tendon destruction. There is swelling and joints become painful. Why there is swelling? Because increased production of synovial fluid, and as joint is a closed space, so there if there increased production, this results in a swelling of the joint. Articular cartilage is eroded because the macrophages and all those cells which are getting activated, they will attack the cartilage, resulting in the cartilage destruction. These are actually destroyed by proteolytic enzymes, vascular tissue in the folds of the synovium, and direct invasion of cartilage by pannus of granulation tissue creeping over the articular surface. Similar changes in the tendon sheaths also causing tenosynovitis. There's invasion of collagen bundles, partial or complete rupture of the tendons. Now, usually once the swelling takes place, as the patient is continuing his or her activities of daily living, there is usually a chance that tendon has now become thinned out or is actually not as strong as it used to be. Therefore, the normal activities during lifting, walking, the tendons may rupture due on the slight amount of pressure, resulting in complete loss of movements at certain joints. And in the diagram below, as you can appreciate, this was the rheumatoid arthritis patient had of the hand and feet. Both feet can be seen here. This is especially formation of hallux valgus. This is first metatarsophalangeal joint, which is actually almost been destroyed. You can appreciate there is no joint line. There is actually bone destruction is very much visible. Similarly, the metatarsophalangeal joints of all other fingers seem to be affected. And now if you see closely, there is increased defect on the hallux valgus on this area, but as you go on, there may be less destruction in the small little toe metatarsophalangeal joint. But it's not necessarily in this patient it came out to be this way, but sometimes the first toe is very much less affected, although it's affected, and other joints are affected more. So there is no clear-cut predilection that first the first metatarsal would be affected and then the other. And similarly, if in one foot there could be pathology could be more severe as compared to the other foot, and suppose for example right foot, there may be in a preclinical stage there might be swelling some degree of this, but if you see it on x-ray the joint line would be preserved. But on the left foot that may be completely involved, or there may be some degree of destruction on the other side. Now on the right side, if you see, there's a picture of a hand, and as you can appreciate how much gross deformity of hand develops eventually when the metacarpophalangeal joints and interphalangeal joints hand are destroyed, that the patient is unable to carry out his or her activities of daily living because of these deformities. Now once this whole the tissue has been destroyed and late stage arthritis has been developed, this would eventually result in deformity. Articular destruction, capsular stretching, and tendon rupture, they all occur. Progressive instability and deformity develops. Inflammatory process still continues, as the problem is not with basically these tendon, but that is due to those production of interleukins. Mechanical and functional effect of a joint and tendon disruption become vital. If you see it over here, now this is a classical presentation of a rheumatoid hand. In this, there is a swan neck deformity, and there is a mallet finger present over here, which is actually the loss of extensors of the distal interphalangeal joint. This results in a flexion of the distal phalanx and causing the formation of mallet finger, and this deformity is termed as swan neck deformity. Now coming to the proximal interphalangeal joint, if there is attrition or rupture of the central slip of the extensor tendon, this may result in the formation of buttonard deformity, in which there is a flexion at the proximal interphalangeal joint, but there is an extension of the distal interphalangeal joint. Now if you see it over here, this is exactly what is happening, and there's a buttonard deformity of the thumb. Then there's ulnar deviation, which usually occurs in the hand, and there is a swan neck deformity and formation of mallet finger over here. Now, if you see this hand, this is also presenting a classical presentation how actually the mallet, now this, the ring finger, little finger, and the index finger are all presenting a swan-like deformity, and there is a mallet finger present in all these three. On the other hand, if you see the second finger, this over here, in the middle finger, due to this loss of central slip at the proximal interphalangeal joint, this is depicting a peritoneal deformity. Now coming to the pathogenesis. Now the point is that once the whole joint destruction has been set in, these interleukins, the TNF and cytokines and prostaglandins, they don't remain confined to a joint, but they actually spread via blood to other organs and exerts their effect. Now they affect liver as well, resulting in acute phase response and iron redistribution. They also affect blood vessels, resulting in atherogenesis, myocardial infarction, and stroke. In brain, there is a results in the low stress tolerance and increased chance depression. As a result, usually the patient with rheumatoid arthritis are also highly demoralized and depressed. In the bone, they affect resulting in low bone mineral density, increased chances of fracture as there is increased osteoclastic activity is going on. In muscles, there is increased disease, insulin resistance, resulting in diabetes mellitus, and increased production of adipocytokines, which further actually causes production of insulin resistance in the body and resulting in diabetes mellitus. Now, rheumatoid arthritis just does not affect the joints; it affects other organs of the body as well, and the most common among them are the rheumatoid nodules, which are usually present on the extensor surfaces of the hand, wrist, and the elbow. But these are the pathognomonic because of the pannus formation. Once these pannus formation occurs outside the joint, this results in rheumatoid nodules. Then there is the lymphadenopathy, which is involved not only present around the joint, but there may be distance lymphadenopathy positive as well in the patients with rheumatoid arthritis. Then there is increased vasculitis due to production of these cytokines and other inflammatory mediators, and this may be a very highly problematic because increased vasculitis may result in necrosis and gangrene of the distal parts of the body, such as toes and the fingers and distal thumb. Now, this also due to this release of the cytokines, this cause muscle weakness, lethargy, and now the joint is also getting deformed and the muscle are getting weak. So the ambulation is actually getting poorer and poorer day by day. And then there are certain visceral changes as well. It affects lungs, it affects heart, and most common usually it also affects the cervical spine. And most common it is actually in the cervical spine, it's the atlantoaxial level, and in the heart and the lungs, it usually can cause MI or pulmonary fibrosis. Now, as I've just told you, the rheumatoid nodule is a small granulomatous lesion consisting of central necrotic zone surrounding by a radially disposed palisade of local histiocytes, and beyond that there is an inflammatory granulation tissue. They're usually present on the dorsal side most commonly, but they could be present on the flexor side as well, mainly on the metacarpopharyngeal sides of the dorsum of the hand, on the wrist, and at the elbow. There is some degree of lymphadenopathy and mild splenomegaly. Involvement of skin, including nail fold infarcts, is common, but organ infarction can occur as well. There is muscle weakness, which leads to generalized myopathy and neuropathy. Localized sensory and motor symptoms from nerve compression by thickened synovium. Lungs, heart, kidneys, and GI tract and brain are sometimes affected as well. The ischemic heart disease and osteoporosis are common complications. Now this is showing how much extra-articular manifestation. As you can see that RA almost affects everything. In eye there is scleritis and keratoconjunctivitis, there is atlantoaxial C1, C2 subluxation, which may be the cause of death because in rheumatoid arthritis there may be a dense fracture which may result in the death of the patient. In if heart, it's the effusion and involving the pericardium as well as MI. In the lung, there is fibrosis, nodule, and effusions. There may be some degree of splenomegaly. Rheumatoid nodules may cause vasculitis and pulmonary edema. There is extreme amount of muscle wasting, thinning and ulceration of skin. In nervous system, it affects the peripheral as well as the central nervous system and resulting in multiple like peripheral neuropathy and compression syndromes. There may be amount of amyloidosis, that is production of beta amyloid proteins and their deposition, especially in the intestine and the kidney. Then there are lymph node increase, lymphadenitis and lymphadenopathy may be positive in these patients. And most common is myocardial infarction and asymptomatic heart ischemic heart disease. This myocardial infarction, pulmonary fibrosis, and atlantoaxial subluxation are one of the most common cause of the death in end-stage rheumatoid arthritis patients. Thank you very much. Keep watching sqadia.com.